Welcome to the Neuroveda Podcast for Complex Health. We feature expert guests who dive into ancient and cutting-edge understandings of health and disease. These conversations are about food, lifestyle, and medicine just as much as about nature, culture, and politics. I'm Gillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine, coming to you from our clinic, Neuroveda Health in Seattle, Washington. And I am thrilled to again be presenting one of our star clinicians. Dr. Brianna Cardenas is a specialist in Ehlers-Danlos syndrome, EDS, hypermobility spectrum disorders, and complex neurologic and immunologic comorbidities, including dysautonomia, mast cell activation syndrome, spinal CSF leaks, cerebrospinal fluid leaks, and cervical cranial instability. She sees patients at our clinic, Neuroveda, and provides remote health consultations worldwide through her company, Healed and Empowered. Dr. Cardenas has a unique and comprehensive approach to patient care, which includes everything from detailed radiologic reinterpretation, particularly in patients whose imaging has been read as normal. Those are the air quotes around normal, to hands-on manual therapy. She's one of fewer than 100 certified fascial counterstrain practitioners worldwide, integrating this highly specialized technique into holistic care for medically complex patients. In addition to her clinical work, Dr. Cardenas serves as an assistant professor in the MEDEX Northwest Physician Assistant Program at the University of Washington, where she teaches future physician assistants. She has lectured nationally and internationally on EDS and related comorbid conditions. Her professional focus is deeply informed by her own lived experience navigating severe chronic illness, which drives her commitment to advancing recognition of these conditions and ensuring that patients who often fall through the cracks receive rigorous, compassionate, and collaborative care. Dr. Cardenas, welcome.
Thank you. Gosh, thank you so much for that introduction. I appreciate you.
Oh, thank you. It's very mutual. And we were just doing so much brainstorming, about what we want to do with what we know. And so I am thrilled that we're talking about what I think is one of the more complex and has been esoteric aspects of connective tissue disease, neuroimmune care, um, inflammation. And so today our focus is really differentiating common neurologic conditions in EDS and connective tissue disorders. So I'm thrilled to be talking about this.
Me too. Near and dear to my heart. I had to figure that out on my own journey, right? I feel like that's how some of us arrive at this place in doing the type of medicine that we do.
Yeah.
But it's really interesting to see how not just patients, but a lot of our colleagues, I think, can get really overwhelmed if you dive into like what could be going on when I have these, XYZ symptoms that
Yep.
happen and they fluctuate throughout the day. It's really kind of a beast to even conceptualize as a person living it, let alone like communicate it in a way that helps your practitioner to start teasing out the pieces. And then, unless you are specialists like us, where you see this stuff in and out all the time, every single day, um, if this is just, a random set of concerns from a patient who's already maybe on the far end of your complexity spectrum of patients that you see, it can be really humbling to try to figure out like how do I even help this person or where should I even start? So I'm so happy that we get to talk about this and hopefully help provide some clarity.
Absolutely. Absolutely. And we were just, I've been working on a talk for another conference, and it's all about neuroinflammation as a central axis for complex and chronic illness. And it really is these things that touch the nervous system can then have 80,000 different presentations, symptoms throughout the body. So if you live in a medical system with silos, you can get trapped in the sleep medicine arena or in the GI arena or in the musculoskeletal or the rheumatologic arena. So just to say that like we can end up being pigeonholed by these symptoms and we can never kind of see the whole picture. And so that's kind of part of what we're going to do with this high level view of neuro EDS today. Yeah.
Can't wait. I'm so glad you touched on the neuroimmunology piece of it because I think that one of the disservices that we do in medicine as a system, at least in the United States, is really try to break things up into like
Mm.
separate parts, and
Yep.
it loses that integrative piece. And like that's just not how the body works. That's
Nope.
Not what it
Nope.
does.
We're just like one bean in here.
Right. Exactly. Exactly. So thrilled to discuss.
Good, 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 good. Okay, so let's start us off. Let's start us off with just kind of this like understanding that EDS, Ehlers-Danlos syndrome, is a disease rooted in the connective tissue. And so as we aim to get to the heart of why EDS presents with neurologic conditions, talk to us first about the nature of connective tissue at its root.
I think that this is one of my other like favorite things to talk about, which is fascia and connective tissue and just like the extracellular matrix, which is like just the goo within us. It's like it's a very scientific explanation, but the stuff that holds us together, kind of the glue that holds us together, in people with EDS or Ehlers-Danlos syndrome, collagen deposition and organization is impaired or dysregulated. And so when we think about what that means, the most readily apparent outward manifestation of that is like, oh, my joints are flexible, right? Because you're like, oh, okay, well, yes, your tendons stretch, that makes sense. But that needs to extrapolate to all of the systems of the body, the nerves themselves, the dura slash meninges, which are the wrappings of our brain and spinal cord, and then the interface between the dura and the really complex uh, vascular system that envelops that to allow for immune signaling, waste removal, et cetera, to go in and out of the brain. And so when we think about the fact that collagen is kind of the gateway to these systems and how they interact with each other, and then think about, well, what would happen if those things didn't work the way that they were supposed to? It can really open the door to just like a myriad of symptoms, everything from structural integrity issues, like we talked about. But if that's happening way up in your craniocervical junction, like there's a lot of important things there, right? Like your jugular vein, the main drainage out of your brain, vascularly, your foramen magnum, which is where your brainstem and spinal cord leave your head and go into the neck, the spinal fluid that has to pass through there, and then the vagus nerve, the carotid artery, like lots of things happen right at that little baby junction. And so if you imagine kind of these chronic shearing forces or chronic irritation on those structures, like it becomes really apparent how everything from a headache to a seizure could subsequently manifest from that. So I think that's important to set the stage.
Yeah.
Um,
When I was first studying medicine, I did a wilderness EMT course in the mid 90s, and they described this structure, this head neck structure, as a bowling ball on a shoestring, like on a shoelace. And, obviously in outdoors, you're getting thrown around a lot potentially by either falls or, whatever it is. But I was like, oh my God, it's true. How do we have this like t this small structure through which all of these very important things connect? Our brain center, our nervous system center to the rest of everything it has to move. It's very interesting.
yes. And it makes a lot more sense for bipedal organism or not bipedal, quadrupedal organisms, like
Hmm.
our evolutionary ancestors. Like it makes a lot more sense if the bowling ball doesn't have to balance on the shoestring, right?
Yes, yes,
But alas, we are bipedal now and we sit in front of our computers now.
yes.
And
Slowly
a lot
becoming
of it.
more.
Yes, I know. We're both doing shrimp posture for those of you listening. We're like in,
Yes.
yeah, like self-conscious now trying to correct our posture here. But when you even think about that, right? Like if your chin is on your chest right now as you're looking at your phone listening to this podcast, you can probably appreciate that things are getting stretched back there. Over time, that ends up creating chronic lack of blood flow to the front of our brains. There's been even some folks in the concussion and like sports medicine world that posit that just bad posture and poor craniocervical alignment is equivalent to like a minor concussion on a regular basis. So as I think about those things, and then I think about like the way that laptops are designed or the way that desks for kids to sit at are designed, like we're really putting a lot of stress and strain on our bodies, even assuming that those bodies have intact connective tissue. And so once you add this connective tissue disease state or dysregulation into the picture, just the amplitude and the speed with which this can really get out of hand and go from like air quotes functional to, really disabling is quite quite concerning for a lot of people and understandably creates this drive to push for trying to get to the bottom of it and find the answer.
Yeah. And connective tissue is also blood, and connective tissue is what makes up all of our um, cardiovascular vessels and all of the tubes of our intestine. Is that right? So you can see all of those things have a kind of meaningful shift in an Ehlers-Danlos state. Is that right?
Absolutely. And I think that, I know that this part starts to get really complex really quickly and can get really overwhelming. And so I would love to introduce like that kitchen sink analogy if that feels fitting. But I give a lot of my patients the analogy of an overflowing kitchen sink. And much in the same way that a sink is designed to have water go into it, hold a certain amount of water, and then drain said water out. Our bodies are designed to deal with stress. They're designed to deal with inflammation. Our tissues are designed to have cellular turnover for some immune response and some inflammation, which is like a healthy part of a healing process to occur and then resolve. So like the immune response, if we liken that to the faucet being turned on, right? And the body's tissues and kind of the space between all of our cells called the interstitium, we can liken that to like the water in the sink. And then the lymphatics, which is part of our garbage disposal system of our body, as the drain, right? All of that is structurally dependent on collagen. And so you can imagine if you have maybe a smaller sink or a drain that's a little flimsy or clogged quite easily, or some other structural change or leaks in your drain, right? Because your capillaries are a little bit more leaky or what have you, right? Or your drain gets compressed because you get vascular compressions more easily than the average person, right? This system can break down in many different places. And then when we add the immune dysregulation piece, right? Because the body has its own intelligence and it can tell when something's wrong with it. And when the body senses that things are wrong with the system, these alarm bells start going off when we're exposed to environmental toxins, when we're exposed to the level of stress that we're experiencing collectively as society right now, when we are exposed to chronic and self-infections. That sends off the alarm signals. That puts us into a sympathetically activated state. And that kicks off our mast cells, which in EDS, our mast cells are already more active, more prone to be overactive. And so our faucet turns on full blast. And
Mhm.
so we get to a place where the faucet is on full blast. The sink doesn't have the same capacity as the other sinks. It's just a little bar sink. It's not a big, nice farmhouse sink. And the drain is getting clogged and it's getting crimped and all of these things, right? It's important, I think, for patients to recognize that the same way that in a situation like that where the sink is overflowing, we can just pause, try to turn the water down, turn it off if we can, call the plumber, get some help, and take it one step at a time. We can do the same thing with our bodies when we understand where these breakdowns occur.
Amazing, amazing. As you're describing the sink, I can't help but think about how many patients I've had diagnosed with like a torturous colon.
Mm-hmm.
Just the idea that that sink, that connective tissue can be shaped in an unusual shape, and that can affect fluid dynamics so extremely. And so here we are in these bodies trying to do all the same things. And I would also just add, without the same reparative or regenerative supports that we evolutionarily were designed to have. We don't have the same amount of sleep. We don't have darkness at night anymore. We have all these EMFs. We have mold in these Tyvek houses. We are attached to screens, as opposed to, listening to the sounds of birds singing. All the things that used to tell us, all the signaling that we used to experience that would tell us from the world that we were safe and we were okay. Birds singing, light and dark cycles. A lot of those things have been removed from our lives. So.
Absolutely. And a lot of us are I mean, I don't think evolutionarily to that point we have the tools to really sit with like the level of suffering that we see in the world right now. And
Yeah.
I don't think even designed to comprehend suffering on like the level and at the breadth that we're seeing it as well. So um, I am validating that for patients on a regular basis. Like we are not living through, business as usual on a regular basis right now. Like being dysregulated is 1000% understandable in the context of being in a chronically ill body and then seeing scary things happen in the world right now. So,
Yeah, absolutely. Absolutely. 100%. 100%. So let's talk about, let's move on to another depressing topic, like how things can go wrong inside the body.
yeah, shift from outside to inside.
Wow, this is a real Debbie Downer podcast. Well, but but knowledge is power.
It is. It
So,
is. And I think it's nice to be able to like name it too, right? Because then we don't feel like we're silently like pulling our hair out and like looking around like, is anyone else feeling this way? So yes, inside the body though, what can we do? What goes wrong here? And like also I think more importantly, like why is this getting missed so much?
Mhm.
Right? Like why are regular community practitioners not picking this stuff up? A lot of it is because understanding the body as a whole versus like as different organ compartments, for example, tends to put EDS in kind of like the orphan disease category. And so you get a lot of like the Spider-Man meme where they're all pointing at each other, where like the neurologist refers you to the gastroenterologist, and the gastroenterologist refers you to the cardiologist, and then back to your primary, and then to a surgeon when you're like so sick that you can't get out of bed anymore. And then you get imaging, and then that imaging is read as normal. And then you're just kind of like chasing your tail.
Yep.
So I think when we think about what happens in the body, we um, don't necessarily have the tools yet in medicine to be able to radiographically um, make some of these changes apparent.
Mhm.
When we think about what collagen looks like, when we think about the size of like a collagen fiber or a mitochondria or a mast cell, these are not things that are going to show up on an X-ray or on imaging until like tissue remodeling has occurred, right? Until the tissue has been undergoing this level of stress for long enough that it starts to make some defensive changes that then you can see downstream. Also, Western medicine is very geared towards like emergency response types of things. Like, can we see the brain tumor? Can we see the stroke? Can we see the disc herniation that's pinching the nerve? And we're really, really good at that in Western medicine. And that's stuff that you can be assured is not going to get missed in many cases. But when it comes to things that I think the larger medical community refers to as functional, I'm using air quotes again. Um, these things, while they do have things that you can see on imaging, they're often not apparent without dynamic movements, meaning like motion types of imaging with your head turned or your head moving back and forth. And they miss what happens with mobility, which is really the key part of like being in a hypermobile body, right? Like when you have a disease state that is dependent on things moving too much, um, we're not going to see that on static imaging. So.
Yeah. So you can look fine when you're still, but then as soon as you take some steps through life, everything goes sideways.
Absolutely.
Yeah. Okay, so that's why we're missing it. And I do, it does over the course of history and like medical evolution, we have, MS was like a hysterical disease of women until we got the MRI and we could visualize the demyelination. And so, the expectation, and I think that you are kind of like a case in point for this, honestly, is that you have your understanding of radiology is why we have you do overreads for a lot of our patients because you can see things in a different way. And so that information should be coming. And as you teach new physician's assistants how to be doctors, this is coming. So rest assured that, in the next 5 to 10 to 15 years, hopefully sooner, We may have better and better understandings of these things, but for those of us suffering from these conditions now, we need to be able to think about them and understand them now, right?
Absolutely. And I think, a lot of it comes down to time constraint and the concept of like being reactive versus proactive in the setting of care. And so if things are not caught by a radiologist who has learned in their medical training to focus on big, scary things that are going to be life or limb threatening within the next year or so, or, in the very near future, that they're not going to be things that are taught in school. A lot of my radiology colleagues have said, like, I've never learned about craniocervical instability. I've never learned about spinal CSF leaks. I've never learned about that except in the setting of like this weird medical complication of a procedure, et cetera, or in the setting of a trauma. And so if they're not these big, profound, issues that are blaring on the imaging, or if it's absent the context of something like a massive car accident or like a botched procedure, it's going to get missed. But there are still findings, measurements that can be done in the literature that's published by like a lot of our peers who are really like at the forefront of being like, hey, everybody, like there's stuff we can do about this, right? And it just is up to people who have the interest to take the initiative to learn more so that they can help other patients. So that's actually what we're going to, I think, be delving into about what can we do as healthcare providers in kind of the community setting to help folks with these conditions, and then what can patients do, and what kind of imaging can they take to their doctors or request that they can take to their doctors or people on their care team to request with specific parameters that will
Hmm.
help these things be caught with more accuracy and without delaying people's care so badly.
Yeah, absolutely. 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 So let's dive into kind of what these conditions are and what we're talking about. How do you go about kind of organizing the differential?
I think of the differential based on like EDS being its own patient population. So when I think about like common neurologic conditions, those are not the things that necessarily commonly affect our patient population. So what we end up running into is that a lot of practitioners will be like, well, you can't have craniocervical instability, you can't have a spinal CSF leak, like that's too rare. But then when you think about in the context of EDS and these connective tissue changes that we've discussed as like the presupposition under which this like body and ecosystem is existing under, um, we then start to see like, oh, well, it makes sense that like if your tissue is more stretchy and more flexible, more prone to tearing or fraying or getting leaky, that like stuff would leak out of it or that stuff would shift out of place. And then subsequently, things like this list that I'll go over in a second become more common in our patient population.
Mhm.
So that list, and kind of, I guess this is by no means comprehensive, but the common things that I see patients coming to me with in our clinic with hypermobile folks are things like craniocervical instability. That also encompasses, now it's called upper cervical instability or UCI, and that encompasses craniocervical, so head on neck instability, or atlantoaxial instability, which is C1 on C2 instability. That also includes things like cranial and spinal CSF leaks, which have different radiographic appearances and require different imaging of different sections of the body. Things like Chiari malformation, things like cerebral venous congestion, which creates high vein pressure inside of the head, which is different than high spinal fluid pressure. There's also just regular high spinal fluid pressure on its own. So when you think about like the three things inside of your skull, you've got your brain, you've got the spinal fluid, and you've got the blood. And if one of those three things is elevated, you're going to have very similar effects. They used to actually call that high CSF pressure pseudo tumor because it wasn't a tumor, but it was creating tumor-like effects. So that vascular change can occur. And then further down, once we move out of the head and craniocervical junction and get further down, we can have things like adhesive arachnoiditis, which is where one of those linings of the brain and spinal cord can get inflamed and stuck to its neighbor or to the cord itself. And then there's also tethered cord, which is like a specific location where that happens with a specific type of connective tissue in the spine. Um, all of those things have significant overlap, and that list was long enough, right? And so if you just see that list and you see the complications and you see the list of things it can cause, you might want to shut your laptop, right? Like it's a lot of information, especially as somebody who doesn't feel well and has brain fog and, doesn't even know where to start and isn't even sure if their doctor's going to believe them or not anyway, right? So, I'm so glad that we're getting to talk about how do we even start to like tease out and make sense of these things.
Yeah. So one way seems like by location, by geography, is that right?
Yes, asterisk. Because
Hmm.
when we think about the body as a system, right, the meninges, like that brain and spinal cord wrapping, go from the top of our head down to our tailbone. Some will argue like down into the sciatic nerves and into like the peripheral nerve sheaths, right, because they have sheaths around them. When I was in school, they kind of were like, yeah, the blood-brain barrier is solid. It's, this tissue that nothing can get in and out of. And it's like this tube down the spinal canal, and that's all you need to know. Um,
Yeah.
That's not true. I kind of conceptualize it more like a centipede wearing a bodysuit, like the cord with its like many different branches. I know, what a great visual, right? Wearing a bodysuit, and that's its like pia mater, the first lining, and then it's got like a mid-weight sweater, that's the arachnoid, and then it's got its like big outer layer, that's the dura. And
Sure.
any one of those things can create tension. So imagine if, for example, somebody came up behind you and grabbed your shirt or grabbed your sweater down by your waist, and then
Mhm.
you tried to lean forward, right? You're not going to feel that necessarily down by where you're getting grabbed. You're going to feel that up at your shoulders and the sleeves, up by
Mhm.
your neck, right? Because like the tension is going to hit that point.
Mhm.
So when we talk about things that happen further down, things like spinal fluid leaks, things like a tethered cord, we have to think about what those structures connect to. And so oftentimes the first presenting symptom of a spinal CSF leak, it could be way down at the bottom, like in your lumbar spine, is a headache. That's worse when you're upright. So location dependent, asterisk, yes, can help us, but by no means excludes other things. So
Mhm. 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 So, well, and I was thinking about kind of where things go wrong, but that is not always where they present. Where do
absolutely.
you, so you can, there's a lot of referred symptoms. Yeah, like pathology in the lumbar spine can present as headache on the top of your head.
Right. I know. And that's just stuff that, when one person, their whole job is to look right at your spine and not at your head, and one person's whole job is to look right at your head and not at your spine, we kind of lose the forest for the trees a little bit. So it really, I think, helps when people can start to organize their symptoms, track their symptoms, and present this data to their care team in such a way that we can start to pull through it. So that is one thing that I often recommend for patients is like start tracking your symptoms. I know it's really exhausting. I know it can kind of make things feel worse in the sense, like psychologically and emotionally, to record every little thing, like when you're getting a headache, around what time of day. But there are some great apps that help with that. There's a free one called Migraine Buddy. There's another one called Bearable. There's another one called Cure. No, what is that other one? Curable was one. I don't know if it's still around. And then Guava, like the fruit, are some of the common apps that our patients use. And having that stuff be available can be really helpful. I know our colleagues at Rhythm Health have like a free AI for patients where they can get like clinical insights. So utilizing AI responsibly and
Hmm.
in a compliant fashion.
Fingers crossed.
um,
Yeah.
it can be helpful to start organizing your thoughts and start collecting some of this data and making sense of some of the trends that you
Yeah.
might be seeing. For example, if you're noticing that your symptoms are predominating at a certain time of the day, that's very helpful to know. If you're noticing that certain movements of your body, like turning your head a certain way, provoke your symptoms, that's really important to know. If you're noticing that certain activities, like anything that increases the pressure in your body, so like bearing down for a bowel movement, being intimate, bending down and squatting off of the floor, squatting down to the floor and picking something up or making your symptoms worse, or even just having, being in a seated position versus a standing position, right? Like all of these things are really pertinent. So even just the awareness of like there is a trend, like your body will show you a trend, are really important metrics to start taking note of.
Okay. Okay. Good to know. Good to know. And so if we started thinking about pressure, let's talk if we started thinking, we kind of came up with this loose kind of structure like pressure, instability, venous, and spinal. So if we
Mhm.
started with pressure, can you talk to us for a few minutes about pressure disorders? High pressure, low
Yeah.
pressure?
Yes, I love me some pressure disorders. They're like my my white whale where I'm just like someday in my career I'm gonna
Let's
figure it out and like make it better for everybody. It's like my like thing that just keeps me up at night and makes my wheel spin. Pressure disorders, it's important to move away from thinking just spinal fluid pressure, especially in our patient population, and start to encompass other fluids like the lymph and the vasculature. So when we know that we have some type of issue that impairs the flow of those things, then we should start thinking pressure disorders. So even if you just have insanely tight muscles on the side of your neck, that impairs the blood flow out of your head, right? If you have craniocervical instability or other structural issues, if you just have congenital arthritis or stenosis in your neck, that's going to impair flow of spinal fluid, right? So just thinking about like how do things align, how do things flow, I think is like an important part of it because even starting to do things like lymphatic drainage, hydrating better, dry brushing, just like moving the fluids through your body for some patients can be really helpful. And that information is really, really good for us to know as your practitioners because it will help us determine um, more patterns in your clinical picture. Um, Pressure is also quite time dependent because it is not just like a closed fluid, like I'm thinking about a water bottle, for example, like one of those plastic water bottles. If we put the water bottle on its side so that it's lying flat, then the pressure distributes more evenly, right?
Mhm.
And gravity gets taken out of the picture more or less, right? So in a human, if you're lying down, more pressure goes up to the head and basically evenly distributes throughout the system. So people who have things like high pressure disorders of the cerebrospinal fluid or venous outflow disorders, which also creates pressure in the head, will tend to feel worse when they're lying down. They will have a sensation of not liking lying down flat. Sometimes that can put pressure on their brainstem. That can create pressure. Oftentimes, I see it more at the top of the head, more behind the eyes, sometimes on the side of the head. And sometimes people will complain that they can actually like feel or hear their pulse in their ears because things are just getting more and more and more crowded in there.
Yeah.
Uh, so being flat very loosely equates to uh, feeling worse flat, rather, very loosely equates to that should be something that triggers us to think about high pressure. And then when you're upright, if you feel worse, all that fluid goes down the tube, right? And out of the head. And so if you feel worse when you are upright or the second half of the day when you have been upright for a while, then we start thinking about pressure deficit in the head. So not enough CSF staying in the head, not enough blood flow getting into the head, etc.
All right. All right. And so talk to us a little bit about fluctuating pressure, like we might call it spiky leaky.
Yes, I know. This is like the thing that has helped us understand, like, again, this is not just like a layer of fabric, right? Like, this is a living, breathing membrane that has interfaces with the lymphatic system as well as the venous and arterial systems, and is also responsive to the chemicals and hormones in our body. So, one thing that's super important for people to know, because this could really help you nail down symptom triggers and symptom things that play your symptoms, is that the more active your mast cells are, the more histamine is going to be secreted into your body and into your brain. And that drives spinal fluid production. So, generally speaking, spinal fluid pressure goes up the more unruly your mast cells are, and the more histamine there is. So if you're noticing that you get a headache after a certain type of food, or you're noticing that you're getting a headache when you get sick and are having, worse environmental allergies, etc., that helps us understand like the immune component that helps that fluctuation. There's also a circadian variation with spinal fluid production. So we make our spinal fluid constantly.
Mhm.
We tend to produce the most of it around 2 to 3 in the morning. So our high pressure people will generally say that they wake up with a headache, or they're waking up in the middle of the night, or I guess like the wee hours of the morning, technically, with a headache. And that should be kind of a ding, ding, ding thing to think about. Like this person could have a high pressure disorder. Um, Also, another fluctuating layer is that anything that impairs, again, that drainage of the lymphatics or drainage of the veins out of the head is going to create more back pressure into the head as well. So, if somebody's headaches have not resolved after getting a concussion, for example, or after getting really sick with COVID or mold or some other viral reactivation, the flu, etc., and the lymph nodes get swollen, and people say, yeah, every time my headache gets really bad, my lymph nodes swell and I just feel really fluey. Like that tells me that there's impairment in drainage somewhere, and we're getting like this back pressure scenario.
And do you want to talk a little bit about the lymphatics, like what's going on with those at night?
Absolutely. So the lymphatics, I think they first were described in literature like in
12.
2012. Okay. And so it was the SLIM, the subarachnoid lymphatic like membrane, which is like one layer of glymph basically inside of the brain. That was like 2022 where they first like described it.
Oh,
So this is like relatively new science. Like I feel really old because I'm like, I was still in PA school before the before the lymphatic system was a thing that we
yes.
knew about, right? And so it's not commonly known, right? So unless you're just like a fascia lymph nerd like us and you're just, continuing to learn all the things and you're like, aha, and like really geeking out about this stuff, it's probably not going to be on your radar, right? And so the lymphatic system is how the brain rids itself of waste. That subarachnoid lymphatic-like membrane, or SLIM, is one cell layer thick. And so any trauma to the head, any massive onslaught of infection that cause a significant amount of inflammation in the brain, any neuroinflammatory issue, any significant disruption in your CSF pressure could, in theory, alter that membrane, right? And then all of that basically has to drain out of the head into the lymph nodes kind of behind your ears and under your chin and down your neck. And so if you have structural issues there that are preventing that flowing or preventing that from flowing, then you're effectively getting kind of like a waste buildup in your brain. And when our brain is full of waste, it's kind of like you're kind of sitting in your own dirty bathwater almost. And yeah, I know, guys. Yeah, we're like just full of them today. But you're just kind of like sitting in your own dirty bathwater, and that same ick that you're like, oh gosh, like that's not good. Your brain feels the same way when it's sitting in its own waste. And then it continues to try to say, well, let me try to flush more of this out. What if I stimulate more of an immune response? What if I send more mast cells to try and clear this out? But if your drain of your sink is clogged and your sink is already full and kind of stagnant, right? Like putting more water in there isn't necessarily the solution. So you're going to experience that as more pressure, more brain fog, more headaches, more neurologic symptoms, eye issues, vision issues, hearing issues, balance disturbance, etc.
Yeah. And the lymphatic system really shifts circadian timing as well. Like, it's more active at night. The lymphatics are more open at night while we're asleep. Actually, I should say while we're asleep. Because for somebody who does like shift work, who's not sleeping at night, that those lymphatics may be more perpetually blunted, which means that even though you're getting enough hours of sleep, you may not really be opening up those lymphatic pathways because you're not sleeping at night. And so it might be that you've got a perpetual source for inflammation.
Absolutely. And that's just like a particularly vicious cycle for our patients too, right? Because if you can't sleep because you're in pain,
Yep.
and the headache is keeping you up at night, like it's unfortunately a difficult balance to correct.
Yeah. I mean, it also means that we've got multiple ways to interrupt all these processes, which is
Yeah,
great. There's so many things that can cause problems, which means there's a lot of opportunities for correction. Um,
absolutely.
yeah. So let's talk a little bit more about the pressure components because when does a lumbar puncture mislead you?
Oh, okay. This is a great question. A lumbar puncture measures your cerebrospinal fluid pressure. If they order an opening pressure. So sometimes they do a lumbar puncture and they don't test the pressure, and they're just looking for things like proteins or bacteria or like other infectious disease or inflammatory disease markers in that spinal fluid. But if somebody's going to get poked in the spine, they really ought to measure the pressure when they do it. That's something that patients can advocate for and ask for their provider to order because, like, if you're going to get poked, you might as well get that information. And that can tell you some stuff about spinal fluid pressure.
Mhm.
However, a lot of times what I see in my patients is that we've kind of suspected, okay, there's a high pressure disorder in the head, and their practitioner may only be familiar with cerebrospinal fluid pressure disorders and not venous congestion issues or venous outflow issues. And so, because there's not an issue with how much spinal fluid pressure there is, that lumbar puncture will often come back as normal with an opening pressure that's considered normal. And then the person is left, with best case scenario, their doctor is saying your test result was normal. I'm going to refer you to somebody who can help you figure this out. But more often, what happens, they say, is your pressure's normal. You go to therapy. This is not a real thing that we're dealing with. And yeah, send it. This is not my problem as your XYZ practitioner anymore.
Yeah.
So it can be really misleading because then patients say, okay, well, I guess my pressure was fine. I don't have high pressure headaches. Um, when we haven't tested the veins. So that's actually one of the theories in like the spiky leaky syndrome, cluster of illness is that the fluctuation, like the body will work really hard to kind of correct itself. So
Mhm.
it's not just the jugular veins, it's not just the lymphatic system. Like you also have lymph drainage out of your skull base by your nose called the cribriform plate. That can manifest as like a very runny nose first thing in the morning if all of your drainage has to go out there, if your jugular veins are pinched. Um, the body will really try hard to self-regulate that. And if somebody has high pressure, whether CSF or venous mediated, to the point where the pressure has been high long enough that they erode through some of the bones in their skull and get a cranial leak, or they form a rip in their dura and get a spinal fluid leak, a spinal CSF leak. Um, these end up creating kind of a muddy picture, so to speak, because now you've got, is it a leak or is it high pressure? Probably both. It's probably the mast cells, right? So being able to ensure that we're like barking up the right tree rather is really important in ordering like the correct study. So like I never in my career have ordered a lumbar puncture for someone. Uh, and we can visualize that stuff with way less invasive imaging.
Yep. Yep. Absolutely. And that's part of that spiky leaky where it's high, it can be high and then low and then every,
Mhm.
yeah.
Right. If you got a lumbar puncture at, 8 o'clock in the morning versus 5 o'clock at night, you could have very, very different results.
It's too bad you can't put like a, what we don't want to do is tap people like a maple syrup tree.
Like with intracranial pressure monitoring. Yes. If we can figure out how to do that like outside of the head, I think that that'll be fantastic. But right
What are
now,
your thoughts about transcranial Doppler? Like in terms of what it is and what it's used for and what could we use it for?
I feel like it could help us in the setting of POTS,
Mhm.
um, because it helps us a lot more with like arterial. Like, are we getting enough blood flow to the head?
Mhm.
Um, I find it a little less valuable with venous disorders, especially if they're in the neck. So, and it's a lot of it's up to practitioner interpretation.
Yeah.
Um, so if, a lot of times what we run into at our clinic is we order the dynamic imaging, like we order the jugular ultrasounds with head turns. And what percentage would you say, Dr. Ehrlich, that they come back and they haven't done the study right?
Yeah, it's real. Yeah. I mean, we just had this last week with this poor patient who was like, I'm now bedbound for days and because it was so exhausting to go out and they just didn't do the jugular vein compression. And we're like, well, we'll just have her come back. Sorry, we missed that. But
Right. Yeah.
yeah, yeah. It's tricky. I mean, I think ordering how to order these images, just like looking at these conditions is kind of new. I'm doing air quotes again in the field. Doing these imaging studies and doing them correctly is also somewhat new. So the same way with ordering mast cell labs, they should be on ice or frozen or ideally done in a cooled centrifuge. And so I will often say to patients, when you go, you can say to the tech, I read on the internet that this was supposed to be kept cool and it shouldn't sit on a counter. Is that true? Like to try to instigate somebody to do their own research. Um, and kind of be in charge of it. But and, and I think it's been somewhat successful and getting labs done correctly, but it's tricky. It's tricky. So
It is. And I think that's like it's like the double-edged sword, right? Where it's like frustrating because like how often are, we having, not us, fortunately, like I feel like we don't have to send patients out of state as often as somebody like in the Midwest might have to,
yep,
right? To
yep,
get
yep,
this type of
absolutely.
imaging done, or this specialized type of imaging done. Um, but then on the flip side, knowing that we have this immune component, we have this connective tissue matrix component, we have these other components that are contributing to these pressure disorders in this living, breathing tissue, right? It's not like there's a hole in my jacket and until it gets sewed, it's not going to get fixed. Like
Right.
it's much more nuanced and complex than that. So it gives us a lot of non-interventional options that we can do for people in the meantime, in order to help improve quality of life and kind of balance that kitchen sink system, so to speak, while we wait for the plumber. So,
Well,
yeah.
yep, yep, because it is actually a malleable sink.
Yes,
It's
it is. Yes. And it like repairs itself. It's just this
yeah,
little,
like amazing. Yeah. So we've talked a little bit about pressure kind of that goes through, we've talked about the pressure through the whole cavity of the head and the spinal cord and kind of in and out. What I feel like we should say, like in verbal parentheses, is that all of those same things can happen in the pelvic cavity and in the peritoneum and in all the squishy bits in the middle. So, there's the hard case of the skull and what happens inside the skull in terms of there's restrictions in tissue, and then all the squishy bits in the middle almost have an opposite effect where it's like, for example, if your liver in late stage liver disease, if your liver isn't producing albumin, the largest protein in the bloodstream that keeps all the fluid, the osmotic pressure to keep the fluid in the bloodstream, or you've got really leaky cardiovascular vessels, then you can have ascites or a lot of fluid that fills in the belly. And so these same things that are happening in the central nervous system can also happen in the GI tract and other places in the body. But that's not our focus today. So I feel like it should be mentioned. But
yeah.
then, yeah.
And that's like what I love about all the people that work with us, right? It's like we're not just like, well, that does that, and therefore case closed. Like when you think about like, well, what is like flimsy connective tissue being in this area of the body? Like that's important to know because that's how people like Dr. Cutchins and like her cohort of folks are figuring out like a lot of POTS is probably pelvic compression and congestion issues. Like that's a whole
Yep.
paradigm that's helping like be a curative cause of POTS. Like what? You know? So
And they talk about all the ptosis diseases. Like a ptosis means essentially drop, but
mhm,
all of the different ways that the intestines and all the GI organs can sort of like drop and squish and move.
mhm.
Yeah, amazing, amazing. So let's come back to kind of like the area of like the jaw, the styloid, C1, C2. Talk to us about kind of how things get disrupted with those tissues and in those areas.
Yes. There's a couple different ways. So being hypermobile predisposes us to those tissues being less stable in the first place. But having that kind of disrupted kitchen sink scenario, like we talked about, creates inflammatory stasis in our tissues. So kind of like that stagnant, dirty bathwater thing that we talked about. And
I'm just
when
gonna
we
feel
have,
like
I know,
barfing.
Every time I know, I'm like, I want people to like watch this podcast because your reactions each time I say that are just fantastic.
It's like your brain is in dirty bathwater. It's not even just like your feet or something.
I know, but how many patients are like, oh my God, you're describing what I feel like every day,
Yes.
and like really validating to be like, yes, like your brain
Yes.
is feeling good because it's not in its ideal habitat, right? But having that inflammatory stasis, if you take inflammation, like if you can get some of the particles that cause inflammations, like cause inflammation states that come out of a mast cell, like interleukin 6 and TNF beta 1, and or TGF beta 1, excuse me, and you get it in a liquid form and you drop it on fascia in a petri dish, the fascia will constrict. It literally, like a shrinky dink, goes from its relaxed state into like
Oh,
this bound up little shrinky dink type of thing.
huh.
And you have fascia everywhere. And so you can imagine with chronic inflammation and those inflammatory particles just kind of chilling there, it's constantly reacting with your fascia and causing it to constrict and get tighter and tighter and tighter. That's why our patients will go try to get a massage, for example, and people will tell them, like, you are the tightest person I've ever felt. Like, your knots are so tight. But you're like, if only I had tightness in my body. Like, what? This is not the case,
Yeah.
but it's your fascia that's tight. And so that tight fascia creates more inflammation, right? It's like this feed forward loop where like the inflammation tightens the fascia and then the tight fascia shuts down the lymphatic drainage and then the inflammation can't leave. So then it just keeps producing itself and signaling more immune reactivity. And so you just kind of get this inflammatory soup right at that junction along your neck. And what it can start to do is actually calcify or harden some of the things in there that should be soft. And so everybody has a little styloid bone. It's the bone right behind your ear, kind of like where the back of your earring would touch if you pushed your ear towards your neck. And it should be about 15 millimeters-ish long. It should stop at or above your C1 vertebrae, the transverse process of it, which is like the sides of the vertebrae.
Mhm.
And the reason that that styloid should stop above that, or like the bony part should stop above that, is because when your neck moves, that vertebra rotates. Okay. And right in front of those little side projections or those transverse processes is your jugular vein and your carotid artery and your vagus nerve. And so when you turn, it like
Everything.
pushes those things toward the front, like toward your jaw, for example.
Mhm.
And if your head has these long structures hanging down that are longer than they ought to be, then every time you turn your head, you're basically bumping those soft structures into those hard calcified overgrowths.
Mhm.
And that does not lead to good outcomes. That leads to, they've now created kind of like a bony tunnel on two sides when it should be soft on another side. So there's room for swelling and expansion and room for the vagus nerve to breathe when you turn your head and not get poked because the vagus nerves in general don't like to get poked by hard things. And when they do, it signals an autonomic response and it puts us in fight or flight and it triggers our mast cells and then it creates some more inflammation. So it's this feed forward loop. So we can get overgrowth, we can get calcific changes. You have a ligament that attaches from that styloid to the bone in your throat called the hyoid bone. That's the bone, like kind of at the base of your tongue almost.
Mhm.
And it's a little tiny bone in there. And there's a ligament that attaches to those two structures called the stylohyoid ligament. But again, it should be soft. And in some people, it calcifies after a concussion, after an infection, after having just chronic pain and mast cell issues. And so that can then subsequently create mechanical changes that create symptoms in our patients. But I will tell you that oftentimes, like there are surgeons who I have referred to that in theory do styloidectomies, which is like removal of that styloid bone, who will tell patients that has nothing to do with your jugular vein, which it's like, sir, it is the next door neighbor of the jugular vein. Like, of course it has stuff to do with the jugular vein. Like, pardon me. But then they're also not used to the C1 moving so much in their patients. So
Mhm.
it's, without the context of understanding hypermobility, a lot of people who even specialize in like the styloid think about it as that bone in and of itself and not in the context of how it interacts with its community. So It's important to keep that in mind. Um, Also, when you factor in the craniocervical piece of that, when you factor in not having enough pressure or too much pressure, that's making you change your neck posture to try to get relief, right? Like those things will end up complicating the clinical picture. And so again, data, data, data. My symptoms get worse when I turn my head. My symptoms get worse when I'm sick. My symptoms get worse at this time of the day. Like all of that will help us to start parsing this out.
Mm-hmm. Mm-hmm. Okay. So we've really talked about CCI. That's the conversation around eagles. So eagles is the name for those long styloids. Do
Mhm.
you want to talk a little bit about Chiari?
Yes. So this is like some people may disagree with me when they hear about it, but some people um, are Chiari purists, like where they think that Chiari is only something that is congenital, like you're born with it.
Mhm.
Chiari is where the cerebellar tonsils, which is like the bottom part of like the back of your brain, grow long and they like poke out into your foramen magnum, which is the hole in your skull. They shouldn't poke out through there because that hole is not very big and the spinal cord needs to fit through there with plenty of room for the spinal fluid. And so if those cerebellar tonsils poke into there, then it's crowded, kind of like my jeans should fit me whether or not I'm on my period, but we know that is not the case, right? So like when more stuff, volume occupies and space occupies, stuff
Uh-huh.
gets tighter,
Uh-huh.
right? And so those cerebellar tonsils, when they poke down and occupy space in there, create a crowded situation for the body.
Yep.
Um,
How do you unbutton the genes of the Corman magnum?
well, surgically, the way they do it is they make the hole bigger,
Hmm.
right? But this is where I am very cautious about the Chiari diagnosis because some people, especially like I remember being in the Facebook groups as a desperate patient, being like, what's going on with me? And a lot of my symptoms overlapped with Chiari. Um, and I so desperately wanted just an answer, and I wanted it to be that. And I wanted it to be like, oh my God, that surgery is going to fix everything. And then I'm going to be back to normal and I'm going to get my life back and it's going to be great. Um, I personally have yet to meet an EDS patient where that was the end of their journey.
Yeah.
Um, I also personally have met several patients, unfortunately, who had that surgery for what they were told was a Chiari malformation and actually had spinal fluid leaks
Yeah.
because they look very similar on MRI. And so, if you have a radiologist who is only familiar with congenital Chiari malformation
Hmm.
and not with spinal CSF leaks,
Hmm.
or low pressure headaches, they might mix them up. In fact, in the presentation that I'm doing for our colleagues next week, I show a picture of what is actually a spinal CSF leak with the brain sagging and the cerebellar tonsils poking down into their foramen magnum. And the research source where I got that picture is a picture of what is a Chiari malformation on
Oh,
Google. So
wow.
like on Google and it was on Radiopia actually, which is like a radiology source. It's actually a picture of a spinal CSF leak, but it's listed under this is what Chiari looks like. So it's so commonly misdiagnosed that like it's wrong in the the online resources for
Wow.
radiologists.
Wow.
And so, very commonly misdiagnosed. There are some easily measurable metrics that we can see. They're more in the midbrain, like a little bit above the brainstem. But in any case, anytime those tonsils come down, um, the knee-jerk reflex from radiologists will be to call it a Chiari malformation. I am not convinced that a lot of what we are seeing labeled as Chiari is true Chiari because a Chiari malformation definitionally is 5 millimeters or more of cerebellar tonsil descent past the skull base or past the foramen magnum into the neck.
Mhm.
And then there's a whole group of people that say, well, you could have 0 millimeters or 1 millimeters and still be symptomatic, which when you think about in the setting of pressure issues, a hypermobile neck, yes, you absolutely could be symptomatic with 1 or 2 millimeters of cerebellar tonsil descent. I personally do not call that Chiari though, until I am certain that we have ruled out high and low pressure disorders. Because if you have too much pressure in the vein on top of your head, that can physically displace bendy tissue. You might have a Chiari looking scenario
Mhm.
from excess pressure in your head. If you have low CSF pressure where your brain isn't sitting up in its normal position where it ought to, and it's dropping down due to lack of pressure, that also can mimic a Chiari malformation. So I don't subscribe to like the Chiari 0 through 5. I am somebody that says like, let's think about what's happening to you and can we find a root cause of it? Because before we bore out a piece of the back of your skull, I would like to try, I don't know, aspirin to see if thinning the blood that flows through your jugular veins improves your symptoms, right? Like, so I would like to try fascial counterstrain. I would like to try lymph drainage before we bore out the hole in your skull. So
That sounds good.
that's just
Very,
my approach. Um,
oh my goodness. There's so much to learn and know here. It's like amazing. It's amazing. So let's keep moving down a little bit towards tethered cord, arachnoiditis.
yes.
Talk about
Uh,
those.
these are the things further down in the back. They are pretty similar in their pathology in the what they call histopathology, which is like what these things look like under a microscope. They're a little bit different. So a tethered cord is where the layer of connective tissue that usually separates from the dura and arachnoid and pia from the spinal cord, called the filum terminale. It's like a little excess strip of connective tissue at the base of the spinal cord around like L1 or L2 in most people. That gets excessively tight and can basically stick the cord to the arachnoid and the dura. And it's kind of like in this scenario where if you stapled your sweater to your back, you're going to get this pulling and this adhesion that is responsive to inflammation. Again, this is in the setting of a system that is a liquid filled tube, right? And so
Mhm.
if you have neuroinflammation because you got a concussion, or because you have craniocervical instability, or because you have other inflammatory processes going on, all inflammation again is particulates, and those particulates are going to settle down that tube of fluid, right? So it's very common that I see people who have suspected that they might have tethered cord, and then they go and get like a surgery to fix one of the things higher up, or they get in a car accident and they have, head trauma, or they have something happen to their neck that really irritates it, and their tethered cord gets worse after that, or they get an infection and their tethered cord gets worse after that. And so it's important to note that again, like that fascia shrinks up on itself. That filum terminale in particular gets tighter and tighter and tighter and gets stuck to the membranes. That usually happens again around L1, L2. Adhesive arachnoiditis is inflammation first, and it occurs in the arachnoid mater area around the lower nerve roots in the spine called the caudal equina collectively, which is like translates to horsetail. And it's several nerve endings in the spinal canal through your lumbar spine. And if you've ever had a trauma to your spine, like a herniated disc, or a bone spur, or an epidural, anything that's kind of interrupted that area and introduced some type of inflammatory issue. And if you've ever had an infection like Epstein-Barr or mold or COVID, and if you're hypermobile and you have connective tissue that doesn't drain its inflammation as well as the average person, you're at much higher risk for adhesive arachnoiditis. Adhesive arachnoiditis is only taught in radiology school in the context of all of those nerve roots, which should be, again, able to wiggle and move freely and have their own kind of space to move around in that canal, when they all clump together and now they're just one big clump.
Yep.
By the time we catch that in a patient at that point, that patient has almost no quality of life. They're almost certainly bedbound and on high dose opioids, because that's actually the clinical treatment recommendation for
Oh,
adhesive arachnoiditis is high dose opioids. So these are
wow.
our patients who have been told that their MRI looks normal. There are failed back surgery syndrome patients, air quotes. They are our patients who have just been told, like, you've just got a bad back. Like, that's all that is. And so again, it's instead of the membranes being stapled together, or excuse me, the membrane being stapled to the shirt, it's like if you had fingers inside of a mitten and the fingers were stuck together. So it's the nerve membrane sticking to each other rather than sticking to the phylum or sticking to the dura. It occurs further down, but symptomatically, it looks almost identical between a lot of patients. Because again, it's creating a tensioning further down in the nervous system that translates to tension all the way up into the neck. So this can present with headaches. A lot of these patients will also have lower extremity bladder and bowel dysfunction. So issues with urinating, feeling like they go to the restroom and they don't quite fully empty, or feeling like it takes a long time to urinate. One of our mutual patients, before she had her surgery for her tethered cord, couldn't pee if she turned her head to the right. And so she had to turn her head to the left to pee. So really interesting how these tensioning things
Yeah.
affect all the way up. So,
Amazing. Yeah. Oh my goodness. Brianna, that's amazing. You're amazing.
thank you.
It's so good. So we don't have a ton of time left, but let's kind of figure out with all of these different conditions that we've talked about, with all these, oh, sorry, with all these different structures that we've talked about, how can we think about diagnostic workup and how do we think about kind of treatment?
Yes. Okay. So diagnostic workup, what I like to see from people before they come to me, because a lot of times, like, people want me to re-review their imaging, for example. I would at least like an MRI of the affected areas where you feel symptoms. So it doesn't have to be with contrast, but like if you have headaches and neck pain, I would love a head and neck MRI.
Hmm?
If you suspect that there could be a bony component, a CT, so I can see the bones better, is very helpful. I like cone beam CTs because they're lower radiation and they just get this little junction right here, like from our ears to the bottom of our chin. And that's what I need to see. Whereas if we do that's, I don't know, like a 4 to 5 inch span. Whereas at least on my body it is, on my husband, who's a foot taller than me, that's probably like a 6 to 7 inch span. But
Uh-huh.
in Western medicine, there's not even an image series that will capture the styloids. I learned that the hard way when I ordered a head CT and they missed the styloids. But if it's a neck CT, then you miss the top of the styloids. And then the radiologist will be like, there's not a study that captures just the styloids. We could do the temporal bone, but you'll miss the neck. So then the solution is unfortunately CT of the head and neck. So your insurance will cover that, but it's a lot of radiation. Ultimately, if we're going to consider potentially sending someone down the line, like the CT of the head and neck with fine slices, 1 millimeter slices is what I order, especially if someone wants to utilize their insurance.
Mhm.
And then I really, really want to see dynamic flexion extension x-rays. Please do not, shouldn't tell people medical advice, obviously, but I do not subscribe to the theory that people need to get the upright flexion extension MRI unless we suspect cord compression.
Mhm.
Our group of practitioners and the people that do fusion surgeries for our patient populations have a set of what they call morphometrics, which are like the measurements on the imaging that we measure. And 3 out of the 4 big ones that they use are bony measurements. So I can see 3 out of the 4 of them on an x-ray without flaring patients, because the flexion extension MRI is extraordinarily flaring for patients. I've had patients have literally 6 to 10 month long flares after getting that image. And I would hate to do that to somebody when it's unnecessary, right? So just supine MRI is fine. It's a cleaner, sharper image that I can measure more accurately. I order flexion and extension imaging of the neck and lateral side bending image of the cranium of the C1, C2. So you have to open your mouth to do it. And I specify on the order, please let patient go to their full range of motion, because a lot of times the radiology tech is not prepared for people to put their chin on their chest and their head on their back, and they don't have their machine set up parameter wise to capture that. And so rather than like zoom out so that they fit the patient, they'll try to make the patient fit what they've already set up. So it has to say on the order, let the patient go to their full range of motion, otherwise they won't be able to.
Mhm.
I also like to order the jugular ultrasound with head turns.
Mhm.
Um, Insurance approves it more easily if we order it as a duplex, carotid, and jugular. So that for whatever reason, insurance doesn't like to cover just the jugular veins unless somebody's had a history of like a blood clot, but they'll include it in the authorization if we order carotid. So I'm like, great, like let's order a carotid and jugular ultrasound. I specify with head turns. And if a patient has a certain position that provokes them reliably, like if they're like, every time I look down, man, my vision blacks out, I get sparks in my eyes, I get all these things, right? Or I can hear my heartbeat in my ears when I look up, then I'll order it with that position as well. And specifically in that order, because all the ultrasound tech or radiologist is going to comment on is if there's a blood clot or not. So they'll just say, hey, it's the vessel is patent, meaning open, and free of thrombosis, meaning blood clot, which great. Like we knew that. We didn't expect that there would be a blood clot. We're looking for like, is there compression on the vessel? And so I specifically request the velocities at each level measured with the head turns. So I want to see how fast does that blood move through there, because it's
Mhm.
like when you put your hose or your finger on a water hose, like the faster it flows through, the tighter it is. So if you're getting velocities like over 80 centimeters per second, then I'm like, that vessel is compressed. So those are really helpful things for me to see. And all of that can get covered by insurance. All of that can be done at the community level. It doesn't need to be like a fancy, you know, UW or tertiary care center or like, you know, complex center, like it can all just be done at the community level. And if there's lower down stuff, if we suspect a spinal fluid leak, if we suspect adhesive arachnoiditis, if we suspect tethered cord, I will order lumbar spine imaging. It's very, very hard to find prone imaging, meaning like on your stomach imaging of the lumbar spine now. The coils on the machines have changed to make that very difficult to do. So I'll order like a sit-up MRI of the back if I suspect tethered cord in that case.
Got it. Got it. Great. Okay, so imaging, obviously, we're going to do lots of different things, but imaging is really this mainstay of looking at the anatomy.
Yes. And then also there are things that people can do like empirically on their own
Yeah.
that can give us more data. So again, like tracking is so, so helpful, even if you just do it for a month.
Hmm.
Um, Checking if there's food triggers, etc. There's something called the 48-hour flat test that Dr. Ian Carroll developed, which is like actually a prerequisite for him to take you in his clinic the last time I checked. And it's exactly what it sounds like. You lay flat for 48 hours, which is
Yeah, you're
hard
just
to
out.
do.
Yep.
Highly recommend prism glasses that let you see 90 degrees in front of you so you can actually lie flat and not like put your chin on your chest to be on your phone for that 48 hours, right? So you can actually see 90 degrees in front of you and stay flat, but look at your phone or watch the TV or what have you. Flat, except to get up and go pee, basically. Just roll on your side, drink a smoothie through a straw type of thing. But you assess your symptoms with a checklist, one, and it's got a list of symptoms 1 through 10, or you rank them in severity 1 through 10, and you measure your symptoms like Friday afternoon around 5 o'clock. You lay flat for 48 hours. Before you get out of bed at 5 o'clock on Sunday, you measure your symptoms again. And if they're markedly better, then the likelihood that you have a spinal fluid leak is very high. And then you get up and 3 hours later, check your symptoms again. And if the only difference is that you've been upright for 3 hours and that's
Yeah.
dramatically made your symptoms worse, then we suspect a low pressure headache disorder. So conversely, if things like compression make your symptoms worse, if things like salt loading for your pots are making your symptoms worse neurologically, if things like wearing headphones, like the big over-the-ear noise canceling ones, because guess what's right there? That dilated that jugular vein, right? If those things are making your headaches worse, or if lying down flat, if you're like, oh my gosh, I have to sleep with my wedge pillow, otherwise I wake up with a headache. If caffeine's making your head pressure worse, if high histamine food is making your headaches worse, then I'm suspecting a high pressure disorder. And lastly, if there is a positional component to your symptoms, we have a mutual patient who I recently saw who was waking up every morning with really bad motion and motion sickness and vomiting. I literally suggested to her to get a travel airplane pillow, like the U-shaped pillow, and put it on her head, like while she was flat on her back sleeping, like a set of headphones. So basically like a big puffy headband so that
Uh-huh.
while she's lying on her back, her head can't tilt side to side. So
Mhm.
just basically keeping her head, you can do that with a rolled up towel. You can do that with putting a pillow on either side of your head, keeping her head in alignment.
Mhm.
Um, it literally resolved her nausea that she was waking up with every single day. So I was like, there's a very clear positional component. Let's
Yep.
look at your MRI. And sure enough, her one of her jugular veins was like half the size of the other one. And I was like, that's our problem. So it's like really nice that we have that like kind of empiric data and we can be like, oh man, like just keeping the neck straight and not sleeping with your head on your shoulder all night, like
Yep.
makes a huge difference.
Yep. Yep. Absolutely. Absolutely. Okay, friend.
Yeah. Should we link some of the sample verbiage like of the orders that I do so that if practitioners want to reach out to us or like how should we share that information with people who need it?
We can put that in the description of the show, so we can link that. And I think that what we haven't done today is really talk about treatment approaches and options, and so
Mhm.
maybe we can do another show. Yes.
Yes, the part two.
Part two, but I think that this is a really good start. Um, and I'm just thinking maybe well, we can talk after, but I'm just thinking like a worksheet would be so helpful for people. I don't know if you
Mhm.
have that, but
We don't have that, but that would be a fantastic resource to share with people, like
yeah.
even to share with our colleagues, right? So,
Yeah, so we'll do some more work in there. Some
yeah.
things going on. So, yeah. Yeah. Anything else you want to mention kind of in closing today?
Yes. If you're listening to this and you're like, that might be me. Oh my gosh, that's what's happening.
Yes.
Please don't give up. Don't
Yeah,
give up. Like,
absolutely.
I remember being at that place and feeling so hopeless and feeling so scared that like people were going to treat me like I was like this hysterical, problematic person, or like, people would gaslight me, and it just felt awful. And like at the time, we didn't have the money because I wasn't working to like see people out of pocket. And I wish that I could have heard a podcast like this, and known that like, okay, somebody's out there that can like at least help my doctor or somebody on my care team, my PA, my nurse practitioner, whoever it is, to help me get closer to where I need to be.
Yeah.
So please just don't give up. Like we're learning more, we're sharing more, we're doing our best to like teach future generations to recognize these things. We go and present on this stuff all the time. Like we're trust and believe everybody that like we are out here really doing our best, as are our colleagues, to make this not so that we're like the tinfoil hat wearing people. The medical community. We're like, we're,
Yeah.
yeah,
Or
we're
the gatekeepers, you know what I mean? That you have to, that's the other idea too. Like there's nothing that can replace a one-on-one medical visit with a physical exam of any particular patient. And so we cannot, obviously diagnose from afar or into the future for somebody who might hear this podcast next week, next month, next year.
right.
But all of that is to say is like we are wanting you to know, well, if you can identify, if you feel like this is you, then that gives your providers an idea of what you think is going on. Because if we can figure out the symptoms of these different conditions and their tendencies, and if that is what you see mirrored in your symptoms, it gives your clinicians an idea of
Absolutely.
how to
And
look.
I know that, like, I don't want to speak for you, but I've seen you do this. I know I do this. Like, if somebody's practitioner reached out to us, like, if a random, PA, nurse practitioner, doctor reached out via email and was like, hey, I'm interested in learning more about this. What can I do to support this patient? Like, in a heartbeat, I will happily talk with our colleagues and be like, yeah, like, welcome. We welcome you to our community of practitioners. Like, how can I help you? So,
Yeah.
yes,
Yep. And it is a lot bigger than just the two of us. We've got other clinicians at Neuroveda who are also doing this work, who are excellent. And then there's a whole world of folks out there. So
absolutely. I mean,
that's
even just the
something we
people
can
that may
add
listen
to
to the podcast. So,
yes. And maybe that's something we can add to that, some kind of worksheet. We will work on that.
yes.
Great.
Awesome.
Thank you so much.
Thank you
Dr.
for having me. I love doing this.
Yay. Me too.
Thank you for listening, everybody.
Thank you. And we love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together and are committed to sharing knowledge and insight that empower us and our communities towards greater health. Thank you for listening to the Neuroveda Podcast for Complex Health, and we will see you next time.